it was clear to me that the neurological system was one of the sort of final frontiers of medicine. It wasn't fully explored. You just know you have to succeed. So failure is not an option. And if you look at neurosurgery as a specialty, it goes back to the originator by the name of Harvey Cushing. You may have heard of Cushing's disease. So Harvey Cushing was a very bad personality. He was a mad genius, but he was a bad personality. And many people he trained carried that on, and that got passed down through many generations. Now I see people who are looking at regenerative medicine options to help avoid surgery, but not just for the spine, because this has blossomed into treating other musculoskeletal structures, joints, big joints, small joints. Just because I was trained to do something in 1994 by someone who was trained to do it in 1971 by someone who was trained to do it in 1949 doesn't mean it's the right thing now. The basis of regenerative medicine is to use that knowledge to cheat, to hack, and to have someone have some youthful healing in an area where they need it. The FDA does not have jurisdiction over what doctors do. And there are thousands and thousands of joint replacements done every day in the US. So one of my goals is to help reduce the need for that. It's still quite a barbaric thing. If we can delay it, put it off, and maybe even prevent it in some people, I think we're doing them a service. You can grow a liver organoid or 3D bioprint it into the shape of the liver. You can regrow, pancreatic islet cells. The bioengineering challenge is to get those to stay alive in the body because they don't yet have a blood supply or a nerve supply.
Sounds like there's going to come a time where humans will never die.
Join Disruptive Doctors.
I'm Dr. Selina, your host and co-founder of Disruptive Doctors. At Disruptive Doctors, we're building a platform to help doctors like you impact healthcare differently. In Postcall, we dive into the untold stories of doctors who are breaking the mold, trailblazers who are redefining what it means to be a doctor. This is Postcall Beyond the White Coat.
Hi, so today I have the honor of sitting down with Dr. Jeff Gross, board-certified neurosurgeon who spent decades in the OT operating on some of the most complex spinal conditions. But instead of staying in surgery, he made a shift, the one that challenges the very foundation of what we as doctors have been trained to believe. Now, he's at the forefront of regenerative medicine using stem cells and biologics to treat spinal and musculoskeletal conditions without a scalpel. Hi, Dr. Gross.
Hello, thank you for having me.
So, Dr. Gross, before we dive really deep in about regenerative medicine, let's start with the bigger question. Who is Dr. Jeff Gross, and what does the audience need to know about you?
Well, I'm a self-proclaimed bio nerd. I've always been interested in biological sciences. I knew I was going to be a physician from a young age. I've always been interested in neurological sciences. I studied molecular biology and biochemistry in undergraduate school, but then, went right into medical school and training, residency, fellowship, and practiced many years in neurological surgery with a focus on spine and other problems. And it was only in the last 6 or 7 years when sort of the light bulb went off and I decided to make a disruptive move and incorporate regenerative medicine into my practice. I'm not only a practitioner, I'm a recipient. I use it on myself. I'm a biohacker. I love all things health and wellness and preventative. And I continue to have projects in this area to push the tip of the spear forward on bringing these natural, logical treatments to light to help delay and slow the need for invasive surgeries and pharmaceuticals and other things that have downtime and side effects.
So what drew you to neurosurgery in the first place?
Well, at the time I was in, undergraduate and medical school, it was clear to me that the neurological system was one of the sort of final frontiers of medicine. It wasn't fully explored. We still don't fully understand the brain function. We are now just tapping into, the neural networks and how our, brain cells interact with each other and relate, which is actually the basis for the mathematical side of the programming for artificial intelligence. So when you see all these AI things out there, they are based upon how our brain cells interact. So I had an understanding of some of how that worked, and the math and the clinical, and it all kind of came together for me early on. And that neurological science was an area where there'll always be interest for me. That was one of the drivers for sure.
Okay, so neurosurgical training, I guess it's been notoriously known as one of the toughest medical training program in
Yeah.
the US as well. So what was the most challenging part of the journey for you?
Well, I think it's learning how to be cool in juggling multiple life and death situations at the same time. In our training, in the middle of the night, I might have been the only neurosurgeon in the hospital, 100 or 150 nights a year for 7 years. When you have one person in the trauma room, three in the emergency room, one in the CAT scan machine, five up in the ICU, and 20 others on the regular ward. You're running around and you have to juggle all this. If you can't figure that out quickly, if you can't juggle all the balls in the air and without making a mistake. So I'm a bit of a perfectionist, probably a little OCD in my personality. So I think you bring all these tools together and you get the most out of them, and you're challenged, and the challenge is like Mount Everest in front of you. Of course you're going to climb it to the top. It's right in front of you. It's succeed or fail. And in neurosurgeons, when they're in their training, they cannot fail. So I think it's a personality and some nature, some nurture. But the challenges were, learning how to be cool in those pressure situations.
You mentioned that there's this thought that you have, you cannot fail. How did you deal with that?
It's almost like it wasn't even a decision. You just know you have to succeed. So failure is not an option. So there wasn't much thought to it. There wasn't much, chewing my teeth over it and worrying about all the, oh, should I still do this and stuff? Yeah, maybe a couple times you second guess yourself early on, but you sign up for this, and I think they pick you to join the training program based on your ability to succeed it. So failure is just not an option. I'm from part of the country, the Midwest, where we have a work ethic. We get the job done. I'm part of a generation that is not lazy, and we don't take things for granted and expect things, and we do the work, and we roll up our sleeves and do it. So that to me was a foregone conclusion.
Okay, I also saw a post I was following this female neurosurgeon. I think her handle is Lady Spine Doctor. I saw a post that she mentioned that the neurosurgical fraternity was really notorious for bullying their juniors. Did you suffer any of those?
For what to their juniors? I'm sorry.
Bullying their juniors.
Oh, bullying. Listen, there are some very bad apples. And if you look at neurosurgery as a specialty, it goes back to sort of one of the originators of neurosurgery by the name of Harvey Cushing. You may have heard of Cushing's disease, for example. So Harvey Cushing was a very bad personality. He was a mad genius, but he was a bad personality. And many people he trained carried that on, and that got passed down through many generations. And some of my professors and residents that were above me in the seniority carried some of that on. And yes, there is some of that, but there are also some people who said, I don't need that. The buck stops here. We can be human, humane, gentle, and loving and still teach. But yes, there was tons of bullying, but the get it done part of a neurosurgeon just brushes it off the shoulder and says, whatever, bring it. Are you done now? Let's move on and help patients.
Well, that's very funny. You mentioned he's a mad genius and how he started this whole thing. I think there's a lot of similarity, like what you're saying with the doctor's personality. Because here we've also done straight up 24 hours shifts, 36 hours shifts with no sleep. Some of us wear that like a badge of honor.
Yes.
I made it through 36 hours. I had tons of bad cases, one after another, but I made it through. And we all used to, now looking back, I don't think I would want to go through that ever again. But there was a point in time in my career where I did that. I put a central line in, half asleep, one eye open, but I got it done under 5 minutes. bloodless. And I felt so proud of myself. Those are the things that I used to wear as a badge of honor. Like, it's 2 a.m. and I can still do this. I still got this. Right. So I think it could be like what you said, a personality thing where not everyone is suited for this. And I think that's the most important thing to know, whether you're suited for the job, like what the job actually entails, what is
Yes.
required of you, and whether you have it in you. Because, like I said, not everybody is cut out for this. Like, just like not everyone's cut out to be a superstar, right?
I couldn't agree with you more. I think that, when you look back at these things, this is one of the ways you really learn the deepest responsibility to care for another person who is maybe in a life or death situation, needs a central line, like you said. And whether it's 2 in the afternoon or 2 in the morning and you've slept or you haven't slept, you have to get it done. So sadly, at least here in the States, that teaching of responsibility, or that forced teaching of responsibility, isn't so great anymore. We have a lazy population of doctors that have work hour restrictions and all kinds of things, and they want to be employed and time off. I mean, that's not how medicine was once upon a time. And there's a deep responsibility that comes with this, and people don't always want that. So thank you for putting the work in and knowing what that means, because I think we're losing that tradition.
I think it's just in the US. I've heard a lot from my colleagues who are still practicing in the government service that this is a problem, that it's a new problem of the generation after us kind of thing. I also remember there was once. I mean, this is a case that I don't think I'm ever proud of. But I remember being on call. I was in the basically I was a periphery call, so I had to run the whole hospital. Like, I have to run all over the place whenever there's acute cases. I have to intubate. I have to, all the cases that cannot fit into the ICU because it's full. So I had to attend to all of it. I remember I only managed to have my dinner at like 12 a.m. Like, my shift started at 8 a.m. I was running the whole time up till 12 a.m. Finally, I had my dinner, and I remember at 2 a.m. I thought, okay, it's a little quieter. I just want to lie down a little bit, right? Just lie down, put my feet up. It's so swollen. I'm so tired. And then I get a call. Doctor, you need to come to the HDU now because a patient collapsed. I just thought, oh my God, what right now? And then I remember I ran all the way there. My specialist was already there. It was a boy. It was a young man. He was probably in his 20s, acute pancreatitis, on chronic pancreatitis, and he collapsed. And I remember thinking in my head, like, I hope he doesn't make it because I'm so tired. I cannot do this anymore. Because if he doesn't make it, if he dies, I get to go to sleep. If he doesn't, every 30 minutes up till 8 a.m., I've got to come. So that's like literally a solid 24 hours of running on my feet. Right. So I remember this incident, and I started to think whether this was a sustainable practice, whether this is a sustainable life for me. Yeah. So I'm thinking maybe those are the questions that maybe some of the juniors are thinking, though maybe a lot of them have not gone through this, but they probably saw what their seniors are going through.
Well, that's why we can only do this when we're young enough to tolerate it, right? And you don't do it forever, because of course you need restorative sleep if you want to have longevity and health. And so at some point you need to learn to sleep again and dream and repair during the night. So luckily that's just during the training years. And then after that, for a few years, I was, a young attending, and I took lots of call, which you get called a lot, but it wasn't as bad. And then at some point I was able to leave that to the younger people. So you don't have to do it forever, but it is a big responsibility. And I congratulate you for those efforts and being honest with your thoughts about, those difficult times when you just, gosh, I just want to put my feet up and rest. And gosh, if the patient doesn't make it, I can do that. And, being honest with yourself is probably most important.
Yeah. And I think what's lacking is probably the honest conversations that we can have about it, because I don't think I've told anyone about this. That was like probably a good almost 10 years ago. Yeah. So there was no avenue to voice this out. It just felt like something I had to deal with on my own.
I'm glad you could get it off your chest here in public.
So what do you do exactly now, Dr. Gross?
Well, I'm very different now. I have a practice where I still see patients with neurosurgical problems in spine patients. I've always had a complex spine practice where I see difficult problems failed problems where they might have been treated somewhere else, maybe had surgery somewhere else and it didn't do anything, and or complications, or people that need that complex second opinion. People that come see me usually are here for a consultation for 60 to 90 minutes for their spine. We look at all the images. Nothing happens fast. It's very detailed. And the idea for that sort of concierge spine second opinion came to me during my training. A colleague of mine, John Fiola, was ahead of me. He was a resident back in Washington, D.C. And he told me about these doctors he knew in Manhattan who would do these half-day consultations. They would dig deep and really get to know every aspect of a patient, because it's in that last minute of a very long time with a patient where you might pick up a clue that tells you everything. So I do some of that, and I treat those patients still because, medicine is pattern recognition, and I've treated spine problems for so long that I can usually figure 99% of them out. And then with the rest of my practice, which is growing now, is my regenerative medicine practice, which encompasses treating the spine with non-traditional means. So traditional would be sort of physical therapies or chiropractic care or acupunctures or even medications or spinal injections, all the way up through surgery for the spine. But my patients came to me, many patients, and said, many of those injections and medications and therapies didn't help. What's next? And I'd say, well, the next thing on the menu is surgery. We should look at the options. Oh, wait, doc, I'm not ready for surgery. I hurt, but I don't want surgery. I said, oh, great, because I really didn't want to offer it to you unless you had to have it. So they would say to me, well, how about this? How about lasers? How about so and so? How about stem cells? And you hear stem cells enough times and you listen to them. And luckily, chance favors the prepared mind. You may have heard that before. So I have an undergraduate background, as I mentioned, in sort of this biology. So instead of going to these annual spine surgery and neurosurgery meetings where people pat themselves on the back for doing the same things year after year after year, that they've been doing since the 1940s. And legitimately in spine surgery, it has not changed thematically since the 40s. You're either making more room or you're locking the spine together in a fusion. Those are the two options. I started going to different meetings and conferences and re-educating and bring stem cells as a new tool into my practice. Now, we refer to that, of course, as regenerative medicine. There are other aspects of regenerative medicine, but when we talk about stem cells, that's really kind of the general theme of that. So now I see people who are looking at regenerative medicine options to help avoid surgery, but not just for the spine, because this has blossomed into treating other musculoskeletal structures, joints, big joints, small joints. We even have things we do for inflammatory conditions and health and wellness, and things that help slow the degenerative and aging process of cells. And when you do that, you're slowing the degenerative and aging process of the body. So that is now the exciting sort of version 2.0 of what I'm doing with most of my day.
Do you still operate?
I do, and I've always tried not to, but now I'm more successful with trying not to, because I have these other tools I can offer people. And I would love not to, I'd be happy if I didn't have to do any more surgeries, and just help people with this more natural, minimally invasive injection type procedures or intravenous procedures using the regenerative biologics.
Do you miss surgery?
I don't miss standing over a patient for 5 hours, doing a reconstruction, but I like the technical aspect and the pride you have when you do a great job and you look at the result and they feel better afterwards. But they have long recoveries. It's very painful. You have to manage them in the hospital. So what I have now is a more efficient means of helping people. And there are so many surgeons overdoing surgery. I don't miss it that much. And I can participate with my colleagues when needed. And I do a few things here and there, but I'm content.
Do you needed a mindset shift to deal with that? Because, as doctors, I mean, we all know surgeons have this view of themselves. They're like the top of the hierarchy, right? You train for years, you develop this really highly specialized skill that not everyone can do, right? It's only the select few that can do, and you're fixing things. So, like right now, you're saying you're trying to not do surgery, you're trying to do other means. I mean, with all the other tools that are less invasive, where you don't have to, open them up and either fuse them or make space. Like, how do you deal with all that? Like, you're now basically what you're doing, every other doctor can do.
No, they cannot. It does require a mindset, a shift of the mindset, a paradigm shift. And that shift did come for me. I was always looking for tools to help reduce the need for surgery. If you think about the fusions we do, and don't get me wrong, these surgeries are necessary when they're done most of the time, although I see plenty that aren't. The what we do with, putting in hardware and fusing the spine, it's still quite barbaric. So if we can do something less invasive or more efficiently or more naturally with less downtime and easy recovery, I mean, isn't that a service to our patients? And what the mindset shift is, you're absolutely right. I spent decades, 7-year residency and fellowship and decades practicing this way. You actually have to stop drinking what we call the Kool-Aid here in the US. You have to take off the blinders, be open-minded, and see what's new. Just because I was trained to do something in 1994 by someone who was trained to do it in 1971 by someone who was trained to do it in 1949 doesn't mean it's the right thing now. And you have to get off of that merry-go-round and blaze a trail to see if you can help people. All of the pioneers in medicine, the real disruptive doctors, have done that. And I hope I'm one of them.
Definitely, because, as you're saying this thing about, as you mentioned, how the techniques that have been done, it's been like for decades and nothing has changed. So I mean, it's not stem cell, but I was diagnosed with Graves' disease a couple of years ago. And of course, I was offered by traditional, I meant conventional way of treating it, which was through medication. If medication didn't work, you just radio ablate the thyroid gland, right? And that's been done since the 1970s. And it's proven to work. And I mean, by working, it means it suppresses the symptoms, but the problem is still there. And I was told, okay, this is the only option for you now because medication hasn't worked. You have to do this. And I think at one point, with my conventionally trained doctor's hat, I said, okay, yes, that's the way to go. But the moment I started questioning if I'm going to still suffer all the side effects, then that's when my consultant said, yes, you're still going to get this thyroid eye disease. You're still going to have flares. You're still going to have all this issue. That's when I had to pull the handbrakes and started looking at, is there a better way to do this? What can I do? And that's how I stumble upon other means of modalities like clinical hypnotherapy, which, by the way, helped me recover from it. I never needed medication ever since 2022. I've been medication free. So I'm starting to see like there's a pattern here. Things we were taught is so outdated, and we should start looking at what's on the frontier.
I couldn't agree with you more. There's the power of the mind and peptides now that can help regulate and anti-inflammatory biologics, to suppress the inflammatory issue. But you're right, you need to look for the root cause. What caused that autoimmune activation? There's what triggered it. Is it something in the environment? Is it stress, whatever? So good for you for thinking outside the box and finding a solution.
I think it's when you become the patient, that's when you see things from a different lens. So when I saw my endocrinologist, the thought that came to mind was, is this how I treated all my patients all this while?
Yeah, I know. I look back at some of the patients I treated and wish I had some of the stem cell based solutions to offer them as an option. We might have still chosen the surgery, but for so many years I did not have that solution. So now I do. So when people come in, I have one more tool than most spine neurosurgeons have.
Do your spine neurosurgeon fraternity, your fellows, do they look at you and judge you differently because you're choosing this option versus the surgical option?
Yeah, some do. I have some close colleagues and friends in the field that are interested. Hey, tell me what you're up to. This is very interesting. Is it something I can put in my practice? And then some are just Kool-Aid drinking, sort of institutional. They're usually part of an academic institution funded by the government. They have to drink the Kool-Aid, walk the walk, say the words they're told to say, and they probably, the Kool-Aid is very strong there. If that phrase means anything to your listeners, that here in the U.S., drinking the Kool-Aid is a reference to this cult where the leader said, drink this Kool-Aid, and the Kool-Aid is a beverage, a flavored beverage, and they all drank it and they died. It's this sort of mindless do what you're told, kind of don't think outside the box mindset. And there's a lot of that in institutional medicine, at least here in the US.
I think it goes across the board because I studied in Indonesia. I did my medical MBBS in Indonesia, and it's almost the same. It's like a frat house. There's that fraternity, and you follow whatever that's been taught to you.
Yeah, so that's exactly what we see here with probably the majority of my colleagues. So I'm less participant in those groups now, and in fact, I've pulled out of some of them. I've gone to those meetings for year after year. They say the same things. They pat themselves on the back for republishing the same data that was published 20 years earlier. They recycle the same stale water. At some point, you got to get off that merry-go-round and look at it and go, wow, I was stuck on that wheel, that hamster wheel.
Before we dive back into this incredible conversation, there are a couple of exciting opportunities with disruptive doctors that I want to share with you guys. First, if you're a doctor who's thinking about moving into a non-clinical career but don't know where to start, or even if you're a doctor who's on the fence thinking if you should leave medicine or stay, the non-clinical career pathfinder by Disruptive Doctors is designed specifically for you. The problem why we doctors think that there's no opportunities for us out there is because we've been trained in sick care all our lives, but that's not true. Healthcare is a huge ocean. What you learn in this workshop is discovering yourself, where to find all the opportunities within healthcare, your game plan, and insights from me and Vivek on how to do it. And the best part is it comes with a 14-day guarantee. By the end of this workshop, you gain so much clarity on what you need to do, or if staying in medicine or leaving for non-clinical practice is for you. Our proven framework has helped more than 1,000 doctors on finding a fulfilling career. So stop wasting your time trying to figure it out all on your own in the dark. So sign up for our next workshop on our website. Next, mark your calendar for Disruptive Doctors Annual Conference and Exhibition. It's happening this 20th and 21st of September. This conference isn't about fitting into label, it's about expanding what is possible in healthcare and reimagining the doctor's role in it. This is where forward-thinking doctors come together to drive real change in healthcare. For those who refuse to settle, this flagship event brings together doctors from diverse backgrounds to explore fresh approaches, share ideas, and connect with a community of doctors to impact healthcare differently. Remember to get your tickets on our website at disruptive-doctors.com/conference 2025. And finally, if you haven't already, please download the Disruptive Doctors app. It is a global hub where you can connect, collaborate, share experiences with doctors across the globe, and you don't have to be limited by geography. This is more than an app, it's a movement. So be part of the community of doctors who are impacting healthcare differently. And also, can you do me a huge favor? If you have not subscribed to the channel yet, please be sure to subscribe because it's subscribers like you that help us bring better guests for you. So whether it's the workshop, the conference, the app, or just subscribing to the channel, be sure to do it now. Now, let's get back to the conversation. Okay, so now let's talk about stem cell, biologics, regenerative medicine. But before that, let's go back to basics. In medical school, all we learned about the stem cells were very theoretical and very little. I only know that they exist in the bone marrow. So can you refresh our memory a bit about what stem cells actually are?
Yeah, great. So we throw that phrase around sort of generically, but it's many things. And I was the same as you in medical school, as well. They were just cells in the bone marrow that gave rise to other cells, and those were called hematopoietic stem cells, right? So you have these cells dormant in the bone marrow, and when you need to make more red blood cells or more white blood cells for your immune system or platelets, these stem cells sort of just, pop them out for you. Well, it turns out we have got stem cells all over our body, and those stem cells stem back from the embryo. So when you are a fertilized egg and conceived, at that moment, you are one cell. And that one cell is an omnipotent stem cell. It can make a person. It's all powerful. And that divides, as you know, into a ball of cells. And that ball of cells flattens out into the flat embryo and makes the three layers, the ectoderm, the endoderm, and the mesoderm. And then those cells, as you start to develop into somites and limb buds start to form, Those are called pluripotent stem cells. They can grow a limb, they can grow an organ, but they can't grow a whole person. They're sort of partially differentiated. And then finally, you start to take the shape of a small human in there, and you're a fetus, and you're made of all stem cells. And the stem cells are also in the umbilical cord and some in the placenta and in the amniotic fluid. And those stem cells are making the baby. And right before the baby is born, those cells are finishing up their pluripotent activity for the most part and become, when you're born, multipotent. And these are the kind, when we talk about stem cells in different treatments, we're talking about multipotent stem cells. That means they can differentiate into different tissues. They can help repair, regenerate, heal, restore, maintain at a youthful rate. They do lose their ability to do so as we age and are exposed to environmental problems. And as we develop chronic inflammation, they're not as good, but they're in your fat, they're in your around the vessels, they're in your other tissues. The vast majority of the stem cells in the human body are called mesenchymal stromal cells, which are, again, these multipotent stem cells. For most of them are mesoderm, so they're structural, they're organs. We still maintain neuroectoderm tissues in the teeth and in the nervous system. And then a rarity of the last embryonic layer called endodermal cells. And those might be in the nucleus of the disc and a few other odd areas. That's the minority. So you can take some of these multipotent stem cells in a petri dish and nudge them back into a pluripotent state in a research setting. That's called inducing them. And the short term for that is called induced pluripotent stem cells, iPSCs. And these are being looked at for potential cancer uses and things like that. A Nobel Prize was won for that discovery by Dr. Yamanaka, who discovered there are a few small nuclear transcription factors, some very small peptides that bind the DNA and encourage these four factors or growth factors to stimulate that cell backwards along the embryonic lineage. So when we look at MSCs or mesenchymal stromal cells for treatment purposes, these are not embryonic. The pluripotent ones are. So all the sources of tissue that we use for treatment, the stem cell, come from either your own body or a donor. And typically those donors are afterbirth products. So a woman has a planned C-section, she has the baby, congratulations, here's your baby. And they donate the amniotic fluid, the umbilical cord, and things like that. So this is very ethical, and that's how it's done. And that's sort of basic stem cell 101.
Okay, you mentioned a couple of things. Like, one thing I wanted to ask, does it matter whether you're treating someone with multipotent versus pluripotent stem cells?
I'm not currently treating anyone with pluripotent stem cells. You have to be under, at least here in the United States, under some type of research protocol to do that with those iPSCs. It is a popular area of interest in research, again, mostly for cancer issues. But when we figure out how to regrow a finger or a limb, it's going to be through those iPSCs. So I'm only using the multipotent, further differentiated sort of non-embryonic stem cells. Those are the ones that are appropriate for use in the US.
Okay, and another thing, you mentioned that right now the multipotent stem cells are taken from the amniotic fluid, from the blood cord, and this is ethical versus non-ethical method. And what would that non-ethical be?
Well, a couple things. So this is hypothetical. There are these myths that perhaps in some places people are getting pregnant and then aborting a fetus to have the fetal embryonic stem cells. I've never heard of it or seen it or read about it. But you hear myths. People ask me all the time, these aren't from aborted babies or fetuses? No. So I don't know where that comes from. So that's one. The other thing is we are not, at least here in the States, allowed to use what's called manipulated tissue. So you could take cells and induce them backwards, induce pluripotent stem cells. And that might be one thing that's not 100% approved yet or ethical yet. So that's one way. Of course, the other thing we try to avoid is if you happen to be getting stem cells from cell culture, you're not supposed to use stem cells beyond 2 or 3 passages. Passages means a division. So the cells divide, they make some more cells, they make some more cells, because then you get the copy of the copy of the copy, and then the telomere lengths change and those cells have issues. So I've seen people that have been to other countries, particularly in Central America, and come back with paperwork saying they've had the 4th, the 5th passage. So we wouldn't do that here. That's sort of a lower quality or a higher risk product. I don't know if that's unethical, but it's certainly nothing I'd offer a family member or a friend. more patient.
Okay, so I'm just curious, using the earlier passage cells, would it be more unpredictable?
Using the embryonic cells could be a more
Like you
unpredictable.
mentioned, like passage 2, passage 3, like the
No.
division?
No, because these are MSCs. They're already multipotent. They're safe and effective. They're probably most efficient if they're not passed at all. Most of what we do, we don't want any passages. I don't want necessarily from cell culture. I'd almost rather have fresh cells, which we can get.
I see. Okay. Well, for our listeners here, we have a podcast with Dr. Christian Rapul on mobilization of stem cells within our bodies. So for those of you who are interested in a broader topic, definitely check that out. So Dr. Gross, from your perspective, how does the body's own stem cell response compare to direct stem cell treatment?
Well, we have this store of stem cells, and like I said, as you get older, they become less effective. But I know Christian well, as you mentioned, and he has some good work, and his supplement product helps release your circulating stem cells into your bloodstream, which has health benefits. So what we do is a bit more powerful than that, although I'm fully supportive of what he does. We look to even more efficient and effective and powerful uses of these sort of perinatal stem cell or related biologics to help someone who's unable to use their own stem cells to heal something. For example, I treat lots of knees. We see cartilage degeneration in the knee, also known as osteoarthritis or chondromalacia, that can progress to a bone-on-bone situation. And many of these patients are offered surgery to replace the knee. Well, following the good work of Dr. Philippe Perngou at the University of Paris East, who's published his 15-year follow-up data on knees, he's well demonstrated that stem cell delivery to the knee, to the chondrocytes of the knee, can help improve those patients' clinical outcome and measure, anatomic status. So we have our own examples, and our results are very similar. So I didn't invent that process, but when I joined the realm of regenerative medicine, I borrowed from all the best practices. What's the best biologic? What's the best way to deliver it? What's the most efficient way to target it? And I put all those together, and that's how we came up with our protocols. So that's where using stem cells or stem cell biologics can help someone where increasing the circulating stem cells in our own body is not fully adequate to do everything we want it to do.
You mentioned biologics. So what exactly does it mean? Can you break that down?
Sure. So, we're using this phrase stem cells because that's been around for decades, right? And we started identifying the stem cells. Well, in clinical practice, 10 or 20 years ago, it became popular to start doing something called platelet-rich plasma, PRP. And this is a very low level, sort of elementary level, regenerative offering where you have your own blood drawn, multiple tubes, spun in a tabletop centrifuge, and you ignore the red blood cells in the plasma, and in between you have the buffy coat, right? This layer of platelets and growth factors, and you can pipette that out and take it from all the tubes and add it together and make sort of a pro-healing, growth factor friendly substance that you can inject into a tennis elbow, maybe a tendonitis, ligament strain. It's used for many other things, cosmetic purposes. You can do microneedling in the face. It's called a vampire facial, for example. You can do it in the scalp for thinning hair. It has a little bit of regenerative capacity. And this is now very popular. You can get this anywhere. Typically, it takes multiple treatments. Stem cells is just a way more powerful way to approach that. And usually you don't need multiple treatments with the stem cells. So that's beneficial. And you could take stem cells out of your own body, but I don't know about you, Dr. Chew, but when I take my car to get the oil change, I don't put the old oil back in it. I want some young, fresh oil. So I like these perinatal donated products. They're tested, they're safe. They come from FDA certified labs here in the US. And then we can use those. But there's yet a third biologic we should mention, which I spend more time with these days. So there's an interesting fact that was learned in that if I were to give someone some stem cells in their vein, intravenous circulating stem cells, those cells would be gone in 10 to 14 days. They would be done and gone. But the benefits would last perhaps longer, if not some of them forever, in fighting inflammation, helping your body repair here and there, and things like that. Not unlike Dr. Drapeau's, product, right? Helps circulating stem cells that go around and do their thing. Well, these stem cells are gone in 10 to 14 days. How does the benefit continue on if the stem cells are gone? Well, the answer is the stem cells didn't do all the work. They actually communicated with our cells, both with our stem cells and our own cells. And they communicate through cell-to-cell signaling, which are small vesicles. You might say small, but Jeff, cells are small. And I would say, I know cells are small, but these vesicles that are given off by cells are even smaller. Whereas cells are measured in diameter by microns, 10 to the minus 6 meters. These small bubbles, these small vesicles, these messaging particles are 1/1000th that size, 10 to the minus 9 meters, or measured across in nanometers, typically 30 or 50 to 150 nanometers across. So you call nanoparticles is another buzz phrase. So these extracellular vesicles are given off. All our cells make these communication particles, and they go to neighboring cells and sort of influence the neighborhood and tell them, hey, we're all behaving this way, behave with us. It influences, it's got mRNA in these vesicles that are delivered and taken in by endocytosis to those cells. And those mRNAs help dictate what proteins are made. Do we want a chronic inflammatory profile of an older degenerated person, or do we want an anti-inflammatory optimal mode, youthful restorative healing mode, and a whole different set of proteins are made by those cells. There are small peptides and growth factors, and there are even heat shock proteins. So you probably know from the Finnish sauna, data, if you go into a hot sauna, it's very healthy for you, right? You release all these cytokines and anti-inflammatory interleukins. Well, those heat shock proteins are found in all species, including plants. And those heat shock proteins are very primitive, small peptides that influence our DNA and what genes are called upon. And some other heat shock proteins, not the other one. Well, you can mimic that. You can get them from exercise, hot sauna, cold plunge, fasting, and other ways. But you can also get them through these stem cell derived, healthy extracellular vesicle signal. So we give you stem cells. Those stem cells deliver thousands of these extracellular vesicles to your cells, giving them a message. So that message is amplified to your cells. Your cells are doing the healing work like you did when you were younger. Think about it. If you're a child and you cut your finger playing with your friends, and you cry, your mother cleans it up and, puts some antiseptic and a bandage, kisses it, and sends you on your way. And 3 days later, you're taking a bath and the Band-Aid falls off and the scab is almost completely healed. But you look at a 75-year-old, they cut themselves, they're bruised. It takes weeks to heal. Why is that? Because their stem cell activity is not that youthful, restorative, wonderful protoplasm that we want. So we can simulate that. And that's the basis of regenerative medicine, is to use that knowledge to cheat, to hack, and to have someone have some youthful healing in an area where they need it. So we now can skip the stem cells and go directly to these extracellular vesicles, which for short, we call them exosomes. And these are stem cell derived exosomes. And we like them for a couple of reasons. One is they do the work of the stem cells. We can get a more highly concentrated dose for a smaller cost because they're so widely abundant, because they come from amniotic fluid, which is a large volume compared to the small umbilical cord in Wharton's jelly, where the stem cells come from. 3, they penetrate through all the tissues better. They cross the blood-brain barrier where stem cells do not. In fact, if you think about a pregnant woman, usually her skin is all aglow, it's healthy, her hair and nails are growing robustly. Usually she feels good and her mood is good, maybe some back pain from carrying the weight. But why is that? She's getting a daily dose of exosomes through the placental barrier. The stem cells aren't crossing into her bloodstream, but the exosomes are. So these stem cell-derived exosomes are really a very high quality and cutting-edge regenerative medicine tool given to us by stem cells. And we can get the stem cell benefits from exosomes. Now, stem cells do have some other advantages. They have a honing mechanism if you get them intravenous, but we're using quite a few of these exosomes, and we're getting at least as good a results as we were with the stem cell treatments. And hopefully we can develop this idea more, because it's blossoming like crazy.
Is there a difference in quality using stem cells versus exosomes?
No, if you have high quality stem cells, they're going to produce high quality exosomes. You can also get exosomes from your diet, bone broth, bone marrow. Some animals also eat bone marrow. They know it's healthy. Certain plants, fruits and vegetables actually produce exosomes that have an impact on our cells. Colostrum, mother's milk, chicken stock, all of these things have some exosomes. You think about it, in most cultures, if you get sick, your grandmother makes you some chicken soup. And why? Because it comes from the chicken stock, the chicken bones, the bone marrow. Those stem cells are made all these exosomes. You can actually eat exosomes. They're pretty robust, and you will not necessarily digest them all. They'll actually get into your system. Why? Because they have a little bilipid layer, and they can survive the stomach. And your cells take them in through endocytosis, and you can get the healing benefits. So that's why we probably drink chicken soup in most cultures.
So, sorry, you mentioned that if we ingest it and it would still go through the first pass through the liver and all? How does it survive all that?
Yeah, well, there's no metabolism. These things aren't metabolized, so they go. Your cells take them in, and by endocytosis. So you probably don't get as much through diet and supplementation, but that's why we do intravenous, and we deal with specific areas in the joints, as I was saying, like the French protocol I mentioned. But if you want to get them to the brain, intravenous, we do nasal spray. We've done breathing treatments of exosomes, stem cell derived exosomes for chronic bronchitis. We have patients who have been oxygen dependent. We've been able to get them off oxygen. We've been using them for other inflammatory issues, long COVID, Lyme's, uh, autoimmune, things like that, because they're highly anti-inflammatory. You think about it, when our cells are working well, they're the opposite of inflamed. When they're not working well, they're inflamed, chronic inflammation.
So we will talk about chronic inflammation in a while, but just curious, are any of this FDA approved?
So the FDA approves marketing claims. So none of these things, PRP, stem cells, exosomes, none of these things are approved for marketing claims, nor is eating chicken soup, fruits and vegetables. None of those are approved for marketing claims. So we cannot market or advertise because they won't let us do that. That doesn't mean a doctor and a patient can't decide that this is an option that might be the best for that patient. So that's a private doctor-patient relationship question. It's ethical. It's handled ethically. It's handled through an FDA certified process that these labs go through to handle the donated material, test it, screen it, quarantine it before they make it available to us.
So, like you say, is this not approved for marketing, right? FDA, not FDA approved for marketing for the claims it does. But what if something goes wrong? Does this become an issue that is not FDA approved?
Again, the FDA has jurisdiction over marketing claims. The FDA does not have jurisdiction over what doctors do. They can only talk about marketing claims of products and drugs, like surgical implants and drugs. So if something were to go wrong, which hasn't happened, knock on wood, um, this is why it's important to have a transparent and open conversation with your patient, educate your patient, and have what's called informed consent, where the patient understands all the options. We certainly let the patient know that this is not yet approved for any claims by the FDA. And we certainly let them know, like I always have as a surgeon, that there are no guarantees with any treatment.
Earlier, you mentioned chronic inflammation. I'm just going to draw back from my experience as a medical doctor trained in a conventional world. We will check for inflammation, but that also is not for your well-being. It's only if there's an active infection. We're going to check if there's any inflammation going on. So how does chronic inflammation plays in longevity medicine?
You bring up a great point in your question. And I was trained the same, right? Chronic inflammation is some kind of thing we check as part of a disease process, like infection, like autoimmune, right? We can look at some blood markers, C-reactive protein, for example. But it turns out that most of aging is the rate of chronic inflammation. Because if you look at two 70-year-olds, one may look youthful and be more active and have more energy, and one may be sedentary and have aches and pains and gray hair, but they were both born on the same date. Why is one person looking and feeling older than the other? Because they aged more rapidly on a biological scale because they have more chronic inflammation. Not necessarily having disease, but chronic inflammation slowly accumulating in their cells. Maybe they didn't have a quality diet. Maybe they were stressed their whole life and never slept, like when you were a resident and I was a resident. Maybe there are other factors. Maybe they live near a power station, they have electromagnetic fields. Who knows what's doing it, but it could be any of these things. And the faster and more chronic inflammation you're exposed to, the more likely you have disease. There are wonderful evidence-based medicine on these topics, okay? The less inflammation you have, the slower you will age biologically, the slower you will develop diseases. So it becomes clear that chronic inflammation is aging. And someone used this great term, I wish I could take credit for it, inflammaging. You may have heard that, inflammaging. So the less area under the curve of time and inflammation, the longer you will have a healthier life, that you'll have a better health span. So anything you can do to suppress that inflammation, eating well, sleeping well, exercising, meditating, flexibility, yoga, other practices, all these things contribute to your longevity by fighting inflammation.
Do we still use the same biomarker, like C-reactive protein for active inflammation? Can you still use the same one for chronic inflammation? Or is there something else that you track?
Yeah, I look at more than that because sometimes that's not enough. I look at from the blood, I look at C-reactive protein, homocysteine, omega-3 index. I look at the lipid profile, which has a relation to inflammation. There are a few other markers. You can see if someone's ApoE4 and all these things. Outside the blood, I look at health metrics. I look at heart rate variability. I like my patients that wear health metrics tools like Apple Watch or Oura Ring or Whoop Band or Garmin or something. So we can track those things very nicely. I also like the biological age tests. Some look at cellular markers like, the DNA test, the true DNA. Some look at antibody, glycosylation, like the glycan age test. So we can use those. And we've actually been able to apply regenerative medicine to people with an accelerated age on those tests and reverse their biological age to where their calendar age is or even less by making these interventions. So we know we can move the needle in terms of chronic inflammation using regenerative medicine.
Okay, so what are the most, I would like to say basic, but the primary indicators for measuring inflammation and aging? Like if a doctor wants to do this in the clinic, like what are these few that they must measure?
Well, I would do, there are some wonderful anti-aging panels out there, but I would do an omega-3 index. I would do the C-reactive protein. I'd do a homocysteine, do a lipid profile. I like to look at hormone panels too, because they have a relation. So many people at younger ages, both men and women, are having declining hormone levels, which correlates with increased inflammation. So we love to help replace and optimize hormones, even in the older population, even if they haven't been replaced for many years. There's wonderful work showing reduced risk of dementia and cardiovascular disease and reduced risk of bone loss in women who are taking postmenopausal bioidentical hormone replacement, for example. So those things I would look at. And then I would pick the biological age test of choice. There are many of them on the market. You might mix them up and try them and see which one measures the best. I use different ones.
Before we dive back into this incredible conversation, there are a couple of exciting opportunities with disruptive doctors that I want to share with you guys. First, if you're a doctor who's thinking about moving into a non-clinical career but don't know where to start, or even if you're a doctor who's on the fence thinking if you should leave medicine or stay, the non-clinical career pathfinder by Disruptive Doctors is designed specifically for you. The problem why we doctors think that there's no opportunities for us out there is because we've been trained in sick care all our lives, but that's not true. Healthcare is a huge ocean. What you learn in this workshop is discovering yourself, where to find all the opportunities within healthcare, your game plan, and insights from me and Vivek on how to do it. And the best part is it comes with a 14-day guarantee. By the end of this workshop, you gain so much clarity on what you need to do, or if staying in medicine or leaving for non-clinical practice is for you. Our proven framework has helped more than 1,000 doctors on finding a fulfilling career. So stop wasting your time trying to figure it out all on your own in the dark. So sign up for our next workshop on our website. Next, mark your calendar for Disruptive Doctors Annual Conference and Exhibition. It's happening this 20th and 21st of September. This conference isn't about fitting into label, it's about expanding what is possible in healthcare and reimagining the doctor's role in it. This is where forward-thinking doctors come together to drive real change in healthcare. For those who refuse to settle, this flagship event brings together doctors from diverse backgrounds to explore fresh approaches, share ideas, and connect with a community of doctors to impact healthcare differently. Remember to get your tickets on our website at disruptive-doctors.com/conference 2025. And finally, if you haven't already, please download the Disruptive Doctors app. It is a global hub where you can connect, collaborate, share experiences with doctors across the globe, and you don't have to be limited by geography. This is more than an app, it's a movement. So be part of the community of doctors who are impacting healthcare differently. And also, can you do me a huge favor? If you have not subscribed to the channel yet, please be sure to subscribe, because it's subscribers like you that help us bring better guests for you. So whether it's the workshop, the conference, the app, or just subscribing to the channel, be sure to do it now. Now, let's get back to the conversation. Okay, so now let's talk about real-world application of stem cells in spinal and MSK conditions. So what does that actually look like in practice?
So, this is what I'm doing a lot of these days. And the low-hanging fruit are joints. So many people have knee problems here in the US. You have a knee problem, maybe sports, maybe you had a arthroscopy surgery, which accelerates the degenerative process. And by middle age, you're getting cortisone shots or hyaluronic acid lubrication shots, and they just aren't lasting long enough. And you go see your doctor, they do an x-ray, and the orthopedist says, well, you're bone on bone, you have arthritis, let's do a replacement. And there are thousands and thousands of joint replacements done every day in the US. So one of my goals is to help reduce the need for that. It's still quite a barbaric thing. It's needed in many cases, but if we can delay it, put it off, and maybe even prevent it in some people, I think we're doing them a service. So we take people, we evaluate them. Where's your pain? The basic history and physical, get to know them. I order a very highly specialized MRI on a 3 Tesla machine, which in clinical practice is the higher quality machine, even though in a couple academic centers they have a 7T and I think an 11T now. But these are the higher resolution pictures where we can really dig in. And I order from the secret menu of the MRI center, I order what's called an inversion recovery image, or STIR. And many times you have to ask for that special. It doesn't cost any more, but it lets us look at the bone marrow just adjacent to the cartilage. Why? The cells that originally made that cartilage when you were a fetus and baby, the cells that maintained that cartilage, replaced that cartilage, lubricated that cartilage, are in the bone edge. And the work of the French doctor I mentioned proved that treating the bone edge was statistically superior, longer lasting than treating the cartilage. Because you think about cartilage, it's a protein product of the cartilage making cells in the bone. Just like hair is a protein product of a follicle cell in your scalp. So the chondrocytes are the cells that make cartilage, live in the bone edge where the bone marrow is, where the stem cells are, where the growth plate is. So we deliver the stem cell derived exosomes to that subchondral bone based on targets we see on that specialized MRI. So we do the clinical correlation with the MRI, and then we bring that patient into an injection facility under sterile conditions using some twilight sedation. And I've already done the targeting, and I will inject into the bone above and below the cartilage. Takes about 6 to 12 months to get the kind of results we want to see because the regenerative process takes a while. And usually it's a one-time procedure. And that echoes the results of the French group who has 15-year follow-up.
So how does you assessing the marrow help with this treatment?
Because we can see inflammatory changes, sometimes referred to as subchondral edema, above and below the knee, or in the spine, they're called Modic changes, named for Professor Dr. Michael Modic of the Cleveland Clinic. And these are inflammatory bone changes above and below the cartilage. When that cartilage is losing its cushioning power, the bone marrow feels it and gets cranky, and it can be seen on an MRI if you ask for the right sequences on a high quality. So we use those for targeting. Dr. Herngau in France, in a separate study, also showed that you could take patients with osteonecrosis of the hip, where the bone marrow dies in the head of the femur, and you can inject stem cells. Of course, he didn't have exosomes when he did the study because they're relatively newer. He injected stem cells into the bone and was able to bring back to life, reanimate the cells of the head of the hip. And they had clinical improvement because guess what? They now can make cartilage proteins and lubricate the cartilage. So the health of the cartilage of the joint is a measure of the health of the bone marrow cells at the edge just adjacent to that cartilage. That's the process of osteoarthritis, and that process can be slowed and reversed.
So does the delivery method of the stem cell or exosome matter? Like whether should you inject in a joint space, intraosseous, or IV therapy?
Yeah, IV therapy, if you have little aches and pains, inflammatory changes everywhere, we've done IV. It's not enough to help you fully regenerate joints, but it can help suppress inflammatory pain. I have a sweet little old lady. She's 82 now. She comes in every couple years because she can't use her fingers because of her osteoarthritis. She can't do her cooking and her crafts. She comes in, we give her an IV, she improves, and I say, call me when you need me, and then she comes in 2 years later. So we can do that. Injecting it to the joint can have benefit, depending on how bad the joint is. But what's happening is you're injecting these biologics into the cartilage, and retrograde, they're going into the bone. Now, remember, the cells are too big to go into the bone. The exosomes are going into the bone. They're small enough to penetrate. Well, I say that's inefficient. The best practice is to put them where they're needed. So I put them into the bone, and I can target them very specifically. And just like Dr. Hernigo, who proved you can get better results and more lasting results by injecting the bone, we're seeing the same thing.
Have you seen any cases of rejection? Because these are external proteins, right?
Nope. Yeah, the exosomes are very, very neutral. They have, I think, one CD cell surface marker, and the body has no idea if the body made it or they're somewhere else. They're completely neutral. They have no passport stamp, nothing. Stem cells have a theoretical risk of rejection, although I've never seen it.
Okay. What about, say, PID, prolapse intervertebral disc? Because I know this affects millions of people, and even I suffered a really, really bad one many years ago, L5S1, particularly bad with radiculopathy. Even the surgeon said if it doesn't improve in a week, we have to do surgery. But thank God, like I didn't have to go through surgery. I insisted on physio and really weight training to get myself better. But would stem cells have helped in this situation?
Well, we have had some benefits from use of regenerative medicine, stem cells, and exosomes in this way. Usually, we deliver it through an injection, an epidural style injection around the disc to help end the acute inflammatory process and start the healing. The regenerative medicine is not going to push the prolapse disc back in. There are some new treatments where we also inject the bone above and below if there's degeneration and bone marrow targets on the MRI, and we have done some treatments inside the disc. The disc is a little more complex than other joints. It's made of two different types of cartilage. The annular ring of the disc is made of a rather regular mesodermal cartilage, so we can get some benefits there. But the nucleus of the disc is one of the rare endodermal embryonic tissues. So there are a couple different projects we're working on where we might do two things at the same time. We might treat the bone above and below, maybe the epidural space, and in the disc, we're looking at some different products, biologic products, to stimulate that tissue differently.
Okay, what about rheumatoid arthritis? Well, there's an active inflammation. Would this benefit from stem cells as well?
Right. Stem cells or stem cell derived exosomes, IV, should be highly anti-inflammatory. So if you have a flare up of rheumatoid arthritis or any of the autoimmune arthritides, gout, thyroiditis, all kinds of autoimmune and hyperinflammatory flare-up situations, instead of going and having a prednisone taper or steroid shots and all the side effects that could come with that, you can have a regenerative medicine IV, which can generally, and at least my observation, suppress and stop that flare up in its tracks and put you back to baseline.
Okay, so how do you measure all these outcomes?
Well, most important, how do you feel, sir? How do you feel, ma'am? Tell me what your symptoms are. And we ask, how are those symptoms afterwards? Also blood markers, right? C-reactive protein, titers, things like that. In some of the joint cases down the line, if they're willing, we might do an MRI, and we have actually shown thickening of the cartilage. For example, I have some knee examples where the patellar cartilage has almost doubled in thickness after a treatment.
If someone were to have a rib ACL complete tear, would the stem cell injection be able to somehow bind it back together?
Yeah, possibly. I've treated a few knee cruciate ligament tears, and we've had good benefit. I've injected both the bone and inside the joint for that purpose. I do inject inside the joint because that's where the fibers of the tendon and the ligament are. And in many of those cases, we see improvement in thickening of the tendon of the ligament. But I do believe that it was probable that there were some fibers or some connective tissue matrix that it follows along that path and can help those fibers find their way. Now, remember, those ligaments are attached to bone. So I always want to include the bone in that treatment. That bone is an anchor on either side. And these things sort of arise of the bone too. So I don't have as much confidence because we don't have the evidence-based medicine yet on those, but anecdotally, I have some good results on that. It's worth trying in the acute phase. What's the worst that could happen? You avoid surgery, or if it doesn't work, you just have what everyone else has. Have
I mean, this is also it sounds so beneficial for patients, right? Like reduced downtime, no scarring, and all of this. But why is this treatment not mainstream yet?
Well, the stakeholders, the people that make money from surgical implants and hospitals and healthcare and and big pharma will be damaged. They'll lose money because this is a very efficient way to go. Now, big pharma has seen the writing on the wall, and they're starting to invest in small, regenerative medicine companies, and they'll put patents to these things and charge a lot of money and ruin it.
Sounds like a David versus Goliath situation here.
Like everything. Yes.
Because I don't think this regenerative medicine and use of stem cell exosomes, it's not super new. It must have been there for decades, being used by the ultra rich before it's now being more accessible to the everyday people.
Yeah, this is not news. Look, there's lore going back hundreds of years about the benefits of young blood. And there are experiments where you take an old mouse and a young mouse and you exchange their blood. And the old mouse has more energy and is more youthful, and the young mouse is sluggish and napping. So this is not new.
I guess that's why Brian Johnson transfused his
Right.
son's blood.
That's exactly right. The parabiosis is what they call it. Yeah.
Okay, so let's talk about another case, like the Christopher Reeves case, right? He's best known for his role in Superman, and he had an accident in 1995. He was paralyzed from the neck down. Would he be a great or a good candidate for stem cell therapy?
Well, let's give Christopher and his wife, some credit. They helped push a lot of the research in stem cell medicine 20 or 30 years ago. They built a very large research building in Irvine, California, on the campus, UC campus there, and had the great benefit of working next door, doing some research during my residency. So I watched that grow up, but it's taken so many years to get to a point where we're doing things now. And what he had was a complete spinal cord injury, and we're asking stem cells to help repair that. That's not far-fetched. We're not there yet. There was a recent study, perhaps in the last 8 months, out of China, where they actually took some spinal cord injury patients like that. They surgically went in, removed the scar tissue over the spinal cord injury, placed some type of biologic, and I can't remember that research article, what they used, and had some benefit. So they were the first group to really show it's possible, but it does require removal of the scar tissue. So it's not here's an injection, you'll be better tomorrow. So we are trying to push the envelope and move the needle on those things, and it's coming. And Christopher Reeve would be a great candidate for that Chinese research. I'm not equipped to do that here yet. I would love in my career if I could. Then I can go back to doing a little bit of surgery then, which I would enjoy. But he would be a candidate, but we need another 5 or 10 years, I think, before we really see massive progress there.
So that will be a time where we could cure paralysis.
I think regrowing limbs and repairing paralysis are doable.
Regrowing kidneys and livers and organs as well, I suppose.
We can do that now, right? You can grow a liver organoid or 3D bioprint it into the shape of the liver. You can regrow, pancreatic islet cells. The bioengineering challenge is to get those to stay alive in the body because they don't yet have a blood supply or a nerve supply. So you have to figure out a way to conjure that. So I think that's the big challenge, and that's coming. Some great people are working on things like that. Some people I know well, and we can grow the cells. We just into a ball of cells called an organoid, and you don't have to have a pancreas. We can just have a new kind of ball replacement pancreas, but you have to connect it to the body's blood supply. That's the challenge.
Would that be possible? I mean, putting that in together with stem cells, and stem cells build the channels or vessels, so to speak.
Yeah, so stem cells are pro-angiogenic, which means they develop the blood supply. So they're using that to work on that. A lot of these organoids are based on stem cells anyway. So they're figuring out the actual peptides and proteins that are in the angiogenic pathways, so they can just sort of bathe the ball in this pro-angiogenic sort of milieu. And so they're getting there. It's coming very soon. It will be stem cell based. Yes, you're right.
Okay, so let's talk about how much is salvageable with stem cells. So remember earlier I mentioned I did my undergraduate studies in Indonesia. So you'll see the worst of the cases. Here in Malaysia, I thought I'll see bad cases, but in Indonesia, you'll see the worst of the worst cases. So I had a case where this man was fixing, I think, an electrical pole or something, and there was a short circuit, and both his arms suffered really severe electrical burns. And as I was cleaning it, it was already gangrenous because the stench was so bad. It just smelled like rotting flesh. So in cases like this, where the tissue is so severely damaged, can stem cells actually make a difference?
Yeah, I don't think a couple things. For wound care, absolutely. One of the common uses of amniotic membrane products here in the US is wound care. People with diabetic wounds or gangrenous wounds or difficult to heal wounds because of the stem cell growth factors, the exosomes, the contents of that product. In terms of regrowing the actual fingers or limb, or that is coming. We know many species can regrow parts. Starfish can regrow a leg, certain lizards can regrow a tail. A human child can regrow a fingertip distal to the nail bed until they turn 5 or 6 years of age. So there are genes that our body turns off, and these might be very active in the embryo. We're learning about those genes. We're learning about the small peptides and growth factors that induce those genes to be active. And I think a combination of stem cells or exosomes that carry these peptides and proteins, sort of like a nanoparticle delivery system, will help someone attempt to regrow. First it'll be a finger, and then maybe more than a finger, and et cetera. So that's not yet ready, but it's coming. And think about, this is where the induced pluripotent stem cells or the embryonic stem cells might be useful. Obviously, this is a research area. It's not yet ready for prime time use, but there were for a long time. If you cut your finger off, you could put what's called extracellular matrix, which has a lot of growth factors and proteins and scaffolding, and you can actually get some regrowth. So we have the ability to regrow our finger. We're just learning how to tap into it.
Sounds like there's going to come a time where humans will never die.
Well, Brian Johnson and others would like to agree with you, and we're pushing the envelope that way. I don't know if that's our goal, but we're pushing the envelope that way. But we have to keep people healthy. I'm talking to people who are involved in radical life extension, and you can live to be 250, but your joints and spine are going to continue to wear and tear. So you're going to need to talk to someone like me who can offer you something to help repair and restore that joint. So that's, I think, why that part of my practice is growing and it's so big right now.
Okay, so let's talk about something else more exciting, like controversial area of regenerative medicine and stem cells in sports medicine, right? I mean, athletes of all levels, even myself included, actually, I will consider myself a weekend warrior, right? We're always looking for ways to recover faster, heal better, extend, even for me, my sporting career, right? So we suffer from injuries all the time. So is there a sort of protocol that people like me can adopt to just maintain our lifestyle, be able to play at, my highest, be able to perform sports at my highest level?
Yeah, I mean, look, you can do all the hormesis. You can fast periodically. You can intermittent fast and feed. You could have a low carb, which is a low inflammatory diet, or anti-inflammatory diet. You could do the hot saunas and the cold plunges, get more restorative sleep. You could track your health metrics, your HRV, heart rate variability, and learn the subtleties that bring you to have a, a better outcome. You can do more flexibility work. You can do high intensity interval training to release the myokines so that and then work on agility and balance to help prevent injury. But if all those things at your best peak are still, you want to get a little more, yeah, we've seen regenerative medicine work. I have a younger, very athletic, active, man who came in. We did some IV stem cell derived exosomes, and most people feel the energy and the boost from that. He's called me a week later, said, I just don't feel much. And I said, it's okay. You're pretty optimized. You eat right, you sleep right, you do all these things, you exercise. But the next day, he sent me a screenshot of his, I think it was an Aura ring. His HRV had jumped up 50%, which is a very big benefit. So he knew his body and his cells were benefiting from that treatment, and it stayed up for a while. So he knew he didn't make any other changes and had never seen that kind of jump before. So, and we have that post on our social media because it was so exciting a couple of years ago. But we've seen that other people. I asked them to track their HRV. So we do know that athletes can have restorative benefits and functional benefits. And we haven't measured VO2 max and things like that. But I would love to have someone do a VO2 max, do a treatment, and then a few days later do a VO2 max again and see if we can move that needle. And VO2 max is associated with longevity. So we do believe that the anti-inflammatory benefits of regenerative medicine would benefit an athlete. We see a lot of athletes for the musculoskeletal stuff. I'm talking about separately, like cardiovascular performance and things like that.
So, is this allowed in professional sports? Is it considered illegal or like, performance enhancer and under the anti doping regulations?
You can look up the anti-doping rules. These aren't considered drugs. The FDA considers them drugs, but they're not considered illegal sports drugs. The amateur group is the same. They can have these things. They're not detectable. We do treat some professional athletes. They don't like people to know, but they do come in and we treat quite a few of them. Here in Las Vegas, we have in the summer, we have a little NBA league, and it's not so little, but we do see some of those people when they're in town, IVs, joints, things like that.
So, is this like an unfair advantage or what is this? Like, is it like part of a protocol or would this be considered an unfair advantage?
Well, I mean, if you had an athlete that, eats very healthy and exercises, another athlete that just happens to be talented and doesn't care and doesn't put the work in, would you say that the one who's working very hard to do all these things has an unfair advantage? Like the tennis player Djokovic, right? He went to a gluten-free diet and got better. He improved his game a few years back. So is that an unfair advantage? I think these regenerative treatments are natural and they are, you can get some of the benefits by eating right and sleeping and fasting and doing all the healthy things. So I don't think so. I might leave that to the sports experts to work out, but everyone has access to this if they want it. So I think an unfair advantage would be one team has access, another team doesn't have access. That would be unfair.
So, for the regular people, should we be getting stem cell injection on a regular basis? Even if say I don't have, osteoarthritis or I don't have any pains and aches, should I still be getting this on a regular basis?
Well, it's a choice. It's a lifestyle choice. So I think part of that question, embedded in that question is, can we help slow the inflammation, prevent the development of osteoarthritis and dementia, which has an inflammatory component, and cardiovascular disease, which has an inflammatory component, and so many other things. And the science behind that is yes, it seems we can. Now, there are no longitudinal studies yet. And of course, who's going to do those studies? Because who would want to be in the placebo arm of that study, right? But yeah, I mean, I do it personally intravenous every 4 months, played around with the dose of what I use. Family members that get it. I have patients that come in periodically. Like I told you, I have a sweet little old lady that comes every 2 years. I have people that come in every few months. We want to help people not only with their health needs, but their health and health span longevity desires, right? And we, in a free society, should have the ability to choose those things.
Is there a protocol that you use for the stem cell treatments that you do on yourself?
So I originally started out a few years back doing a smaller dose of about 520 billion exosomes, stem cell derived exosomes IV every few months. I picked every few months because I felt energy benefits, cognitive sharpness, recovery from workouts, better sleep, better other things. And that sort of petered off after 3 months. So that's where I got that 3 to 4 month window. And then I didn't feel it each time as much more recently. So I've jumped up the dose and then I felt it again. So I don't know if I'm just optimizing my inflammation more and I wanted to feel it, or maybe I'm older and it was time to change the dose. So we customize for individuals based on their size, their inflammation profile, what they feel or don't feel, and what they want to get out of it. And then, of course, we consider cost because the higher the dose, the more the cost.
Well, what's the biggest misconception about using stem cells?
I think the biggest misconception was that, they would be very difficult to handle and utilize. Turns out it's quite easy. And any clinician could do it. Many clinicians are doing this. I'm one of the few doctors in the US following this bone injection protocol for joints and spine, the French protocol, but some others do. Most doctors are usually ER doctors that are done with their emergency room life or family practice or sports medicine or even plastics or cosmetic, and they're just doing joint injections. They don't have the surgical background or wherewithal to do the bone injection in a facility. So I think we're a little more advanced there. But the biggest misconception I deal with is on the patient side, the myths. Oh, are these from fetuses? No. Isn't this illegal? No. Well, the FDA hasn't approved it. You can't do it. No. The FDA hasn't approved the marketing claims. The FDA doesn't tell doctors what they can and cannot do. The way they write things up might make you think that because they want you to think that and they want you to drink their Kool-Aid, but that's not the truth.
Yeah, even I used to think that you need to get FDA approval because as I'm talking to all the stem cell producers here, their first thing is we need to go and get an FDA approval before we come here and get the approvals from our the local authorities?
Well, I don't know what the local rules are and how they utilize the American statutes, but Congress in US set up the FDA to evaluate and protect consumers by evaluating marketing claims so we don't have snake oil, right? So fake stuff. And with our new administration, and Robert F. Kennedy Jr. is very pro regenerative medicine. So I hope that these things are cleaned up and the pathways are easier so patients have better access.
Okay, so for doctors who want to get into regenerative medicine or learning how to use stem cells in their practice, what can they do?
Well, just like we learn so many things, you start by reading and researching and watching videos and go go to a regenerative medicine conference where you can rub elbows with other people who are doing it or reach out to someone you want to learn from and come visit us and see what we do on a day-to-day basis. I mean, make a little mini fellowship out of it, something like that. It's not difficult. You look at the logistics, you look at the sources of the biologics, and again, you might be in a situation where your only source is autologous, where you have to take from either the bone marrow or the fat. We have some patients that have had their fat harvested and sent to a biobank, and the biobank pulls out the stem cells and freezes them, and then divides them out in culture when needed, and then sends them to me. It's very expensive and laborious and time consuming, but we're happy to do that too. I don't think it's the most efficient thing, and I don't think it's the most efficient thing economically or medical effect, but that's okay. We can do all these different methods.
Okay, so for our listeners out there, we're running a conference, Disruptive Doctors Conference, this 20th and 21st of September. And what's different this year is we are going to talk about longevity medicine, because I think, like what Dr. Gross mentioned, it's not in mainstream because of certain reason. And I think a lot of patients are already embracing this. They're experimenting, they're trying. And I think the sad thing is us doctors are so left behind. We're in the dark. We don't want to talk about it because, it's not taught to us in our medical school. So we think that, no, we cannot explore this, we cannot do this, and that's not science. So I think that's why we're trying to break this myth and say, hey, longevity medicine is the future and we should start to learn about this and embrace that knowledge.
Yeah, I couldn't agree more.
Yeah, if not, we'll just be stuck with barbaric ways of treating patients.
Yeah, that's what we were. I'm proud that I was able to step off of that wheel and watch my colleagues on the hamster wheel just keep going. And, they're doing the same thing that's been done since the 40s. So gosh, 80 years, 80 plus.
Do you feel like a born again doctor? Like you came out and you saw that what we've done in the past it should stay in the past, some of them, and we should start embracing something new.
Yeah, we should always be looking at new ideas or considering them or evaluating them. And things in the past may still be useful. Like there's still a need for surgery. There's still patients who have to have surgery, but surgery is certainly overdone. There are way too many joint replacements, way too many spinal fusions. I've been fighting against that my whole career, and now I'm doing even better at it. I don't know if I'm born again, but I've seen the light, and there is more than just what we learned in medical school and training.
Yeah, I completely agree. I just remember the case when I was really young. One of my family grand aunt or someone, she fell. She had a femur fracture, and I'm not sure what happened. She had a total hip replacement after that, and she has been wheelchair bound ever since.
Yeah, and we all know that being wheelchair bound diminishes your bone density and increases your aging and has so many deleterious problems. So that's a sad story, but there are so many ways we might be able to address something like that short of keeping her in a wheelchair. So sorry to hear that.
So, okay, so Dr. Gross, I've got one final question, which we ask all our guests.
Okay.
How do you see yourself impacting healthcare differently?
Well, I want to continue to be the tip of the spear in stem cell derived exosomes. I have a project going on right now where we have access. I think we're one of the few places in the United States that has access to what are called natural killer cell derived exosomes, or NK cell exosomes. NK cells, as you know, are part of the immune system, a very small percentage of it. NK cells are known to circulate and identify cancer cells and senescent cells and remove them selectively without harming normal tissue. This is done by exosomes secreted by NK cells that carry enzymes that cause that cell to lyse, to burst open, and then the contents are recycled. We now have in our freezer here NK exosomes that I was able to procure. They're very hard to get. There takes quite a bit of work to separate out the NK cells and then to get the NK exosomes. So we see that as a potential augmentative treatment in patients with cancer, whether it's circulating cancer or injected into solid tumors. And of course, as a surgeon, I can inject. We also see it potentially as a preventative. People may be at high risk or people trying to prevent a recurrence after being treated elsewhere. So I see myself pushing the envelope there. That's our big additional project we're working on.
Okay, thank you, Dr. Gross, for this very, very insightful, and it's a really insightful conversation. So for those of you, if you've enjoyed conversations like this, be sure to join us at our annual Disruptive Doctors Conference that's happening on the 20th and 21st of September, where like-minded doctors like you come to share your ideas and impact healthcare differently. And if you've not downloaded the Disruptive Doctors app, be sure to download it now and connect with a global network of like-minded doctors. That wraps up another episode of Postcall. Until then, I'm Dr. Selina.
Join Disruptive Doctors. Oh, Disruptive Doctors. Impact